swap. You see that we have lots of different things in here. Some of you guys are going to be talking about anxiety. Some of us are going to be looking at sedatives to try to help people sleep, calm down. We have weight loss medications. We have stimulant medications. So very diverse topic that we're going to be looking at. So when we're going through this, same thing applies with us talking about like our ELOs, what we're targeting. If anybody misses anything or misspeaks, I will correct it. So the same exact thing is just to help y'all get more involved and invested as well. So ELO, same thing that we always have. Make sure you're looking at your mechanism of action. Make sure that you're looking at when we have our SIPs come up. I don't need you to remember all of the SIPs, but remember the common things that we talk about. If I have something that's an inducer versus if I have something an inhibitor, what's happening to my drug levels? Going back to our first exam that we had, okay? So if you see that the doses, there's no doses in here that I want you to pay attention to, so don't worry about that. And then we have our brand and our generic names. Remember, your brand names are the ones that are in parentheses. Those will always be capitalized. When you're studying, just again, reiterating for the pants, they don't have brand names on there. I put brand names on there for you guys to see them and be familiar with them whenever you're in phase 2, and we just say brand names, like, because that's what you guys are going to start doing. You're going to be like, I'm not saying that generic name. The brand name is a lot easier. So that's why I put them so that you can subconsciously kind of see them. They're not on any, like your pants or any of that. Nobody's testing you on them. I'm not making you remember a generic and a brand name. I just have it there so that you guys can kind of passively see them. Or when you're studying, because some of these brand names have a lot that you can see and gain from them when you're actually trying to answer a question on the exam, because the brand names kind of tell you sometimes what they do. So that's also why I have them there. All right, our sedatives and our hypnotics. So when we look at these, we like to talk about our GABA receptor. Y'all have already told me about GABA a little bit. We said GABA is going to inhibit things, right? You've seen this before. You've talked about GABA before. Same exact receptor that we have. When we're looking at our mechanism of action of some of our medications that we're talking about sometimes some of them will directly bind onto that GABA receptor, and a lot of them are going to bind into those allosteric sites to where they cause that conformational change in the receptor. So you'll see different ways in which they can work. So this is just showing what just happened. Sorry, y'all. So this is just showing you, hey, here is this drug. Where is it binding onto that GABA receptor, right? So we have several different things. Don't forget about alcohol, because when we're talking about a lot of these medications, if your patient drinks, especially if they drink a lot, then you're likely to see more CNS depressants, more issues that are going to happen. Alcohol is the one thing that is going to be interacting with almost every single drug when we're talking about our sedatives, because those are also going to be depressing the CNS system as well. And then looking at this, just understand that essentially GABA receptor is what we're talking about. GABA inhibits. Don't think about GABA as being something that is exciting. We're trying to stop the excitation from this receptor. All right, we're talking about our barbiturates. These are very old drugs. We still use them a lot. They are very addictive medications, which is why you see us trying to stay away from them. If we use them, we try not to use them for a long period of time. When you think of these, I kind of think of acute situations. So when we say acute, that's meaning like something that is an urgent situation that's happening right now, and I'm trying to stop it at that very second. Do I leave them on them for a long period of time? No. Sometimes I'll put them on some of these meds, and then I'll taper them off of them because I want them to be on something that's more stable for a longer period of time with less horrible side effects. And one of the big ones being like the abuse potential that you could potentially see some of your patients end up having because they've been on these for a long time. When you're looking at our mechanism of action, just understand that this is potentiating, right, those GABA effects that we are trying to see. And we're trying to use our drugs to get those effects potentiated. When we're looking at our clinical use, just think about like trying to calm things down, right? So if I'm trying to put my patient out because I don't want them to remember something, so that's that hypnotic portion that we have with these medications. I can use these in anesthesia. IBS, we talked about this when we looked at like our GI. We have some of these different drugs that we can use there. Your scopolamine, remember that was the patch that we could potentially use. You have your phenobarb, and then paying attention as we go through this, some of these will say C whatever next to them, stating that that's a scheduled drug or a controlled drug, meaning it has a higher abuse potential. So anytime you see controls, that's why we have them as a control. So for you, when you're prescribing them, make sure that you're protecting your license, make sure that you're not leaving these patients on these for a long period of time if you do put them on them. And if you put them on put a patient on these, the longer that they're on them, the longer that your taper off of them will likely have to be. So you can't just put them on them and be like, oh, that's somebody else's problem, let them figure it out. When you put them on there, make sure that you're bringing them back and make sure that you're tapering them off. Don't just refill them because somebody else did it. Also, if somebody else had them on there and they've been on there for a long period of time and they haven't been tapered off, then that means that you might be the one who's responsible for starting to taper them off, unfortunately. And they're going to get mad at you because you're taking away their feel-good drugs, okay? So make sure that you're paying attention to why people are on some of these. Looking at your management of your seizures and your eclampsia, we kind of touched on that. And then if you have very high doses, you'll see where we can get that hypnotic effect, but there's a balance that we have to do when we're looking at this. And we'll look at a chart that'll kind of talk to you about those doses. The higher the doses get, the more likely we are to experience some of these undesirable side effects that we have. So when we talk about those side effects, our big issue that we're worried about is CNS depression, okay? CNS depression meaning I can't, like, if you give me a high enough dose, I could potentially die. I could potentially go into a coma. I can't breathe, okay? Yes, you will get some of those sedative effects, but we might take it a little bit too far and it's permanent, right? Like you're permanently putting them to sleep. So CNS depression is our big worry, especially as our doses continue to rise. This hangover effect and those withdrawal symptoms kind of go into what we were already talking about. So if I'm using this to sedate someone or put them to sleep, whenever they do wake up, especially if they didn't have enough time before they went to bed and after they took this medication, so let's say I'm supposed to get 8 or 9 hours of sleep, and I went to bed and I only got 5 hours of sleep, and I took this to help me go to sleep. I'm likely to wake up with a hangover effect, meaning I still feel kind of groggy, I still feel like a haze kind of over me because this medication still hasn't worn off yet. So that's what it's saying when you see hangover effect as we continue to go through a lot of these slides. That's what the hangover effect is. And then we talked about this withdrawal, so making sure that if they are on it for a long period of time, that you don't just cold turkey be like, I didn't prescribe that to you, I'm not giving you a refill. Like, oh, okay, you've been on a very high dose of this for a long time. Let me know, why are you on this? Talk to your patient, okay? And some people, whenever they have a problem and they have become addicted, some of them realize that and they tell you that. And they want help and they want to get off of it. But that's if you ask those questions. If nobody asks them the questions, they're going to keep taking the medication because it's easier for them. Going through withdrawal and getting tapered off of these medications are sometimes very uncomfortable and people don't like it. Okay, so just keep that in mind. Like your job is to make sure that they are on a medication because they're supposed to be. Overdose treatment. We don't have anything to necessarily reverse this. It's all supportive care. I can try to pump their stomach to get it out. I can do all of these other things, but there's nothing that I have that is a direct antidote to say, hey, let me get this medication out of this person's body, okay? And then looking at your interactions that you have, this is kind of what I was talking to you about whenever I opened up, right? If I have an inhibitor, what's happening versus if I have an inducer. So if I have an inducer, you see that I'm going to be kicking this drug out a lot faster versus if I have an inhibitor, now I'm going to have that sedative effect hanging around for a lot longer, okay? So now my person is going to be drowsy longer. Now my person may experience those CNS effects for a longer period of time where they're drowsy and they're out of it and they can't function. And if I give them these doses quickly enough, like back to back, and they're not spread out enough or I didn't account for the fact that I'm giving them that CYP inhibitor, then I can have pronounced effects that could potentially lead to that CNS depression altogether. This is the chart that I was telling you about with us doing our dosing when we're talking about our hypnotics or our sedatives when you're looking at your barbiturates over your benzodiazepines, or what you'll hear people say as benzos. So when we look at this, what you see is I have my barbiturate. As I continue to increase my dose of the barbiturate, I can start to see my side effects increase. These get worse as I continue to increase my dose. We don't want our patient to be here, okay? So if you have somebody who has suicidal ideations, things like that, this is not a great drug for them, especially if you give them large amounts. Because what can I do? I can increase my dose on my own, and I can get myself to where I think I want to be, right? So paying attention to your patient population is also very, very, very important. When we do have patients who need these, sometimes what we do, some providers they end up most of the time being in BH. They will either observe them taking the medication in front of them, or they will give them very limited amounts. Sometimes the limited amounts is still iffy because what if I'm just holding them at home until I get enough, right? So you have to think about that if you do want to end up specializing. You kind of get very creative with how you want to administer these. And if I were comparing this to a benzo, I have what's called a ceiling effect, right? So I can continue to give these doses. I can continue to increase how much I'm giving. And then after a while, I taper off, right? So there's no more max effect that I'm going to be seeing here. So you have a ceiling that you reach, and then it kind of plateaus off, okay? So I'm not as concerned here as I am with a barbiturate, okay? Older drug, more serious side effect profile when we're talking about these drugs, okay? This is a list of all of your different barbiturates that you have that are available to you to choose from. What you note is that all of these are controlled medications. When we talk about some of these, you'll see that sometimes with the schedule, you can change what schedule a drug is. So whether it's a C4, C2, C3, it can change depending on what we feel like the abuse potential is going to be. All I want you to remember is that they're controlled. If I tell you it's a control, I'm not going to make up a control number and say that you need to remember a C2 or a 3 or a 4. I just want you to know that they're controlled medications, okay? Looking at your clinical use, this is essentially what we were already talking about before, right? I'm using these sometimes for seizures. I'm using these sometimes for anesthesia. We have a preference on when we like to use some over the other. When I make, I almost said I was going to do something, and I don't know if I have time. If I make a review for you, I will try to prioritize how we're going to do this and try to see if I can make a cleaner, easier chart for you to try to remember which drugs go where. But that is what you're looking at here, saying the same clinical uses that we talked about before are the same ones that are here. That WADA test is a is a procedure that they do to try to see, they're essentially putting one side of the brain to sleep to see if a person can retain information and be able to speak. So it's examining their language and their memory function. So that's what you'll see your amobarbital typically used for. Your side effects are listed here. Just remember the big ones that we're worried about are going to be that CNS depression, right? Because that can kill them. But you do see that you have some sexual side effects, which are a big thing for some of our patients, all right? The depression, again, watching out for your patients who are already depressed, especially your patients who have depression with suicidal ideation. You're definitely more concerned because I can use these medications to achieve my end if I would like. And then your serious side effects, we'll talk more about some of these because they come up again, but you'll see your SJS, again, that's that rash that breaks out all over their body. So if they start to have a hint of that, kind of know what's going on. And the other one just know that it affects my bones. Whether that's osteopenia or that bone marrow suppression, just know that it's affecting my bones. Looking at your contraindications, the big one that I want you to understand here is if somebody has respiratory disease. Why are we worried about respiratory disease? Right, because I'm going to further depress their respiratory system whenever I give them this barbiturate. So that is the big contraindication and the one that I want you to focus on there. that respiratory disease. Looking at my drug-to-drug interactions, we kind of touched on these already, but when I talk about my barbiturates and what they do, they're inducers. But then you see that I have other medications, alcohol, other drugs that I could be using that cause CNS depression. So if I tell you that another drug has CNS depression, I now have those additive effects whenever I'm giving them this barbiturate as well. Looking at your decreased efficacy of your contraceptives, okay? Big thing, because if I don't want to be pregnant, and now you gave me a medication that's decreasing the effectiveness of my contraceptive, I need to know that, okay? And I need to know that I need a backup method. Yes?
So going to slide 7 again, where with the DDIs, chronic use of cyclophosphamide for inducers enhance metabolism, and then they barbiturates are CYP inducers. Is there auto-induction?
There's no, not auto-induction. Just, so remember we have several drugs that can act on several CYPs.
Right.
So know that they can induce other drugs. And they can be induced by other drugs, is what this is saying.
Thank you.
Or inhibited by other drugs as well. All right, our benzos. So benzos, people think about these as like the party drugs. And we hear about them a lot more now. Very common drugs, again, that can be used. These are like a newer version, a kind of safer version if we were comparing these to our barbiturates, right? So I can get some good effects from them. I can have very similar effects. So you see I have that hypnotic again at higher doses. I'm helping with anxiety, trying to calm my patient down. We'll see this sometimes used inpatient for our patients who are going through alcohol withdrawal, when we're trying to say, hey, I want to calm down that agitation that they're feeling, the discomfort that they're feeling, the anxiety that they're feeling about breaking this habit. We've used these medications. You have your anticonvulsant properties that we have, and then also like that hypnotic effect that I was telling you. So just producing amnesia in some situations. If you have a short procedure that you're doing, you'll sometimes see that we can add our benzos on there as well to try to help with that. But what we're not getting from these, we're not helping with any of the pain that the patient is going to be feeling. So if there is, this is usually a part of a cocktail, okay? And then that's all this is saying down here at the bottom. The relaxation, essentially, that's happening is more so from the central action, not necessarily the autonomic, like calming down their autonomic responses. So big picture here, most of the time when you see this used, it's more so for the anxiolytic effect of it. Inpatient, a lot of the times we're using it for our alcohol withdrawal or anticonvulsant properties. Okay, when we look at this, we have short half-lives and we have long half-lives. When we're talking about this, this deals with the lipophilicity of that drug, and then we'll look at the chart that kind of goes over that. But when we're talking about a short half-life, most of the time these also have quick onsets as well. So if I have an acute or an emergent situation, I am going to like to use my short half-life. I am just trying to gain control of my patient at that moment, right? I'm not trying to snow them. I'm not trying to knock them out for a very long time. I'm just trying to control that anxiety, that agitation, what have you, at that moment. What you will see is that over time, if you continue to administer these medications, you'll start to slowly see that dose increase because they're going to develop tolerance to this medication. And then as their dose increases, remember this was the one that we saw where we had that plateau effect, right? So I'm increasing the dose, and most of the time my response also doesn't increase. Great thing about it is my side effects don't either. And then, again, higher doses, more likely to have that withdrawal happen. So whenever you see withdrawal, always associate that with, I should taper my patient off of it, okay? So even if you didn't start the medication, your idea behind it would be to say, okay, let me taper them off of it. Looking at my longer half-life. So this is for my patients where I'm trying to control their symptoms because they have a lot of breakthrough, they have a lot of potentially anxiety or symptoms that they're experiencing potentially from alcohol withdrawal, what have you. I'm going to want to put them on one of my longer acting medications because I also may not have to dose it very frequently, right? I can just give this to them a couple of times throughout the day, maybe. But I am likely to experience more of that hangover effect because they are staying on for a longer period of time. So you'll see some of your patients where they're kind of like out of it. They kind of look like they're glossed over. And then you do see with this though, that I don't have as much withdrawal because my drug is slowly releasing and it's slowly wearing off. It's not a quick on and a quick off. It's a slower on and a slower off. Okay? So that's all this is telling you here. My adverse effects. We already talked about the sedation and that hangover effect. More likely to see this in our drugs that have the longer half-life. Looking at your rebound insomnia. So we say, hey, I'm going to help put you to sleep, right? But if I continue to depend on this medication to put me to sleep, and then all of a sudden I run out because you went on leave and there's nobody else who wanted to see me as their patient, and now I'm out of my meds, right? Or I went on vacation and I left my meds at home, which that happens a lot too. If I have that abrupt discontinuation, now what you can see is that some of your patients will end up having that rebound insomnia that happens. With this, if you are trying to taper someone off and you start to see this happening, one, it's very short-lived, and you tell them that you're sorry and good luck. But you tell them like, hey, if this continues for a longer period of time, then what you do is you can slow down their taper. So slow down how fast you're getting them off of the medication. Anytime you taper somebody off of a medication, if those symptoms start to come back, your goal is to say, all right, maybe I'm going too fast. Maybe I need to slow down your taper. You should see that those symptoms will start to slow down, like how fast they're coming back, and then eventually you can get your people off. Sometimes you'll taper somebody off and you'll see that those symptoms come back so hard that you have to put them back on the medication and then extend your taper even longer, okay? The goal isn't to make them uncomfortable. Are they gonna be very pleasant? No, they will not be very pleasant. But you don't wanna increase the uncomfortability that they're feeling as you're tapering them off or getting them off of these meds. Again, anytime we're talking about withdrawal symptoms or that rebound of any type, you're likely to see that with your short-term over your long-term meds. This anterior grade amnesia that our patients will have, essentially this is how we're talking about that hypnotic effect that we're also getting from the medication. So we're using this side effect to our benefit. So we took this side effect and essentially made it one of our clinical uses, right? If I don't want you to remember what a colonoscopy feels like, I can add on a benzo to it, and now you don't remember. You just feel happy and clean and skinnier after you have the procedure, right? So when you think about this, these are like some of those cocktails that we use because we're trying to say, hey, I don't want you to remember that. We have this also in a lot of our other anesthesia as well, but you'll hear where some people, they'll wake up during the surgery because the meds wore off and they remember it, and then they have PTSD from waking up and seeing that their guts were on the table or whatever. So big important thing that we use, it is very common for us to use this, especially when we're talking about our anesthesia. Looking at how long should we keep somebody on these. So this is going to be your job because maybe you didn't prescribe it, but maybe you have one of your patients, you're doing your med rec because y'all are great PAs, and you're going to do your med rec. You do your med rec and you're like, dang, she's been on this for 6 or 7 months. Like, what's going on? Okay? That should make you say, hey, I need to look out for this because there's a reason why this person is still on it for a long time, or we put them on them and we forgot about them, which also happens, okay? So we're trying to keep them on this for 3 to 4 months. This is for us to try to help that patient, especially if they have depression along with that anxiety. Our antidepressants take a while for them to work. So we can try to get them on that antidepressant, give that antidepressant time to work, and then we will taper them off of these medications. There are several medications that you will see that we will start with an antidepressant, and then we'll try to taper them off of that other medication and leave them on the antidepressant for a longer period of time. So when we talk about these, just remember that the longer that someone is on them, the longer that your taper will have to be. And if you are tapering them and those symptoms start to come through or they start to have withdrawal symptoms, slow down your taper for your patient, okay? Increase the dose back up a little bit and say, all right, instead of me dropping their dose by 25% or 50%, whatever you decide to do every week, now I'm gonna do that every 2 weeks instead. and see if that works. You also have to take into account your patient and listen to your patient, right? Because sometimes we're going to be like, there's something wrong with you. I know you're fine. But don't always feel that way and feel like you know how your patient is feeling, right? We're not in their shoes. We don't know what that medication has done to them, but you should be able to eventually taper them off of it. Because if you don't, you have dependence. And that is what we're worried about, which is why we're limiting it to that 3 to 4 months, okay? So dependence is essentially you saying like, hey, I need this medication. If you take this medication away from me, that's when I have my withdrawal symptoms. It's the same thing like we talk about when we have people who use illicit drugs, right? They depend on them. They are addicted to them. We can do the same thing with our medication. Opioids are not the only drugs that we worry about that we prescribe. Okay? These are also big things that we worry about also. Looking at your withdrawal symptoms, again, the same things. These are what you would be looking for, the symptoms that you would look for. On an exam, if I were talking to you about this, I'm going to tell you that they're going through withdrawal. I don't need you to diagnose that they're going through withdrawal. I would say, hey, this person is going through withdrawal. What medication could they have likely been on as to why they could be going through that, right? So kind of looking at when am I worried about this? More likely to see withdrawal in my short term, or my short half-life, or my long half-life drug? Short. When do I use my short? For acute situations or more of my chronic situations? Acute, okay? Looking at some of my interactions that I have. These are all things that could also cause CNS depression as well. So again, just pay attention to some of these that we have. Alcohol, antihistamines, our anti-psych medications. And this doesn't mean that you necessarily are going to always be able to avoid these combinations, because you will see these combinations, but you're watching out more for them. You're asking your patients, are they experiencing any of these symptoms, okay? They experience the symptoms, and that's when you're starting to say, okay, I need to be more creative. I either have to change one of these medications that they're on, they need to stop drinking, or I need to take them off of this benzo. Your interactions, again, that you see, making sure that you're understanding that you have your SIP, that you're worried about your alprazolam, clonazepam, and temazepam interfering with that, and then looking at your lorazepam, oxazepam, and your temazepam or your LOT. These are the ones that you're going to have less interactions with. So benzos don't interact a lot with those 3 medications, right? Your lorazepam, oxazepam, and temazepam. How many more do we have? Almost there. 4 more. I'm going to finish this, and then we'll do our break. Looking at our pregnant patients. When we look at this, just make sure that you understand that if somebody does it, it probably won't be you that keeps your pregnant woman on a benzo. Some situations, we cannot get them off of them. Some situations, it is more beneficial to keep them on them than to have them off. So it's kind of like when we're talking about our psych meds and things like that, you kind of get into a sticky situation when it comes to these. So if I were to ask you, like your answer for the exam would be no, because they can cross our barrier. I.e., I would not ask you that because this is very conditional. Your older adults. When we talk about our older adults, this is one of those meds that are on our Beard's criteria. So remember we talked about that. When we talk about our older patients, we're worried about them. We don't want them to fall. We don't want them to be dizzy. These are things that are going to commonly happen as we get older anyway. So we don't want to increase the risk of that happening with our medications. So looking at this, you have that increased risk of that confusion, the dizziness, the falling. So that's why we're worried about these. So make sure that if you're doing this and you do want to try them, because we love our geriatric patients a lot, we have those same 3 medications that if we did need to use them, we can use those 3 as our options. So your lorazepam, oxazepam, or your temazepam are again your options that you have available in your elderly patients. Okay? So least likely to interact with our SIPs was our LOT. Now we also have it for our geriatric patients. When we're looking at our dependents, your patient history plays an important role. You have some people who have families who have highly addictive behaviors. And so a lot of the times you may say, hey, I don't want to take any pain meds. I don't want to take any meds that I have the potential to abuse, right? I want to stay away from them. That is the patient's choice. So make sure you get that history because you never know genetically what could be behind why someone wants to avoid something, and you're giving them something to help them, and then it ends up hurting them because now they can't get off of it, okay? So I have that for like my family, addictive behaviors, whether it's addicted to a video game, whether it's addicted to alcohol, whether it's addicted to a drug, addictive behavior. So for me, I don't like pain meds. I don't like anything that makes me feel fantastic because I'm like, I might get addicted to feeling good. Okay? So you ask your patient that because you don't know what their strength is, right, in being able to avoid this. Because of that dependence that we have, you have their control medications again. I'm not going to ask you or like make up a control. I will tell you, like you see that it's a question that's asking about that. I'm not going to say, oh, is it a C2 versus a C4? If you see a control that's talking about these medications as well, just make sure you know which ones are. Looking at the physical dependence and that liability. So again, we already talked about this liability. I'm more prone to being addicted to something, probably shouldn't give you this. If I told you I used to abuse drugs in the past, probably not a great idea for you to give me this. And then when you're looking at that dependence and that withdrawal symptom, so the physical dependence is again, me feeling like I have to have this medication. If I don't have this medication, my body is physically going to withdraw from it, okay? That is what we try to avoid. That is why we don't like to use these medications for a very long period of time. So the lowest dose that you could possibly use is great for you to get the effect that you want for the shortest amount of time. And that's with most of our drugs that we're going to talk about. We always start low and go slow is what we say. And then if you can stop it soon, stop it soon. As soon as that person gets through that hump. Sometimes people are going through situational things. I could be going through a divorce. I could be going through, I broke my leg and now I can't run and I used to run all the time, right? So don't put them on these and forget about them. Here we have a rescue, right? So we have a newer drug, which was our benzo, and now I also have something to rescue them just in case they did overdose, right? So your flumazenil is what we have as an option for us to use for our patients. IV medication. Looking at this, it's trying to compete with that receptor that the benzo is going to bind to. So it's competing on that site and trying to knock it off so that we don't continue to have those sedative effects that we're having on with our patient. Okay? Quick onset, short duration. So you might have to run this for a little while depending on how much that patient had. If it's a longer acting benzo, you'll also see that we might have to run this a little bit more versus our short, it's going to get on, quick on, quick off kind of thing. Our longer is where you'll see us running this for a longer period of time. Now, just like we talked about immediately stopping one of our benzos, if I give you a reversal agent that's kicked all of my benzos off of that receptor, I'm now hitting that same exact law where you can see your patient having those withdrawal symptoms. Okay, so remember, it's like that fine line, and a lot of your patients are going to have these withdrawal symptoms that occur very rarely, but you can see it where you see those seizures. And then our uses, again, just trying to reverse, essentially, if somebody had too much of one of our benzos, whether it was a procedure, whether they were at home and they decided to do this, we're trying to reverse that issue that they had, yes.
Similar at all to, I think it's called Narcan, or there's something involved.
So, yeah, they're everywhere. So Narcan is for your opioids, like your pain meds. Different drug class, right? And we'll talk about that next semester, but the same kind of idea of trying to kick the drug off of the receptor to reverse the effects that we would be seeing. And then just understand also, like we talked about our seizures, just make sure that if that does happen, because we're going to kick that drug off, we're likely to see those withdrawal effects and potentially those seizures occur. So just have everything ready to go because we don't want to have our patients seizing and we're not prepared. Here are all of your benzos that you have available. You see that most of these are going to end in like a PHARM or a LAM, right? Your one that's kind of weird is your chlordiazepine or your Librium. And we're going to see this again because we use this, depending on where you are, you'll use this a lot with alcohol withdrawal, or a CWA protocol is what it's called. So make sure that you're just kind of looking at these in our clinical uses, because as we go through, you're going to see these drugs discussed in these specific areas. So I know the question would be like, hey, do I need to know the clinical uses? And yes, this is a summary slide of the clinical uses of when you're going to see these drugs again, because these are all of the different topics that we're going to be talking about right here, okay? Looking at some of the comments, the big things, if you see anything that you're talking about alcohol withdrawal, you're going to see that CELA listed there, so your Clinical Institute Withdrawal Assessment Protocol. You go in, you ask the patients questions, try to figure out if they're awake, because some people, they may be out of it, they could be in a coma, and that's what's scary when your patients who are alcoholics are withdrawing, or if they've taken these medications for a long time and you don't know, and they're withdrawing and they start to seize and you don't know why they're seizing. So we go and we ask them questions, and you tell them, hey, just be honest with me so I know how to treat you, and I have the medications that we need to properly treat you. So you have the CELA protocol. It tells you how to dose all of these medications. And then you have your lot that is here. So your L, your O, forgot our T. It's not on here. I didn't put it on there. So make sure you write it in as to which ones are going to be added on. And then looking at your clonazepam, this one I wrote in here because a lot of times we do see this prescribed incorrectly for anxiety. And this is not something that we would typically want to use for our anxiety, but we sometimes will see it on our patient's profile. You ask them why, and they say that's why they're using it. A lot of these you will also see being used for recreational purposes. I think they call, are these the ones they call bars? I need to get up with my street lingo for it. So these are like, and the reason why is because it comes in like, it comes in a bar, and then you can break off the pieces. So it's beneficial for our patients because depending on how anxious I am or how I feel, if you gave me a 1 milligram and I didn't need a full 1 milligram at that point, I could break off a piece and it's already scored for me, and I could just take that one piece to help me like calm down in that moment. Cool, that didn't work. All right, let me have just another. So that's what it was for, and then we said bars. Somebody had their hand up somewhere. I think I missed something somewhere. No, I didn't. Okay, so yes.
You said to add a benefit to the PHARM.
So, I was talking about here how I had preferred in liver disease or elderly. I forgot this one. The temazepam. That was it. I was trying to make a summary chart and I missed one. My bad. Okay, so let's do 10, and then we come back, and then group 1 will start. So 2:15 or 14:15.
It's been like 15 fucking
That's why I said all of them.
Oh yeah, I saw it. It wasn't a it wasn't a hot. It wasn't a hot. It was a contract with voting. It was contract. It was a voting contract.
Have they run me myself?
Oh, that's what I should do.
Makes me.
I like my
Spiked up all night, just sitting in bed. Oh. It doesn't affect me like that. I'll have bad sleep.
So because look, if they don't have 5K or a will, they're fair game.
6 weeks.
Maybe it was just dude, they're all like that.
Is it so like,
You still need to study. You still need to study.
He's got a couple, he's got a scope out.
That's the, yeah, that's where the ratting, yeah, ratting.
He's going.
Monday is a virtual day, so stay, turn on the virtual and just study.
Hey, we're gonna get paid.
So you still don't have to expect?
The higher the number.
Alright, let me go over something real quick. Okay, on this barbiturate slide, This is a medication that is a combo that has all of this stuff in it, okay? So some of this stuff like we've seen before, right? But this is all into this one pill. And the phenobarb is the barbiturate portion of it, right? Because we saw some of this before. So this is just one pill. This has all of these different ingredients in that one pill, okay? The other thing is this. So just delete this out, right? Just know many of them are substrates of our SIPs except for your lot, okay? So just delete this, cross it out. I know y'all don't use PowerPoint. Cross that out. I don't need you to try to remember it that way. And it's messed up. And then on this is what I was telling you that wasn't in there, right? So this was the same one that was a part of our lot. So having this in there, okay? That was it. Okay, where's my group one?
Okay, so the first drug on the non-benzos is, I looked it up, buspirone is how you pronounce it, buspirone. It is used for anxiety mostly. It's kind of a one-trick pony for anxiety. The MOA is not fully understood, which means probably not be tested on the MOA. Probably, right? It mostly targets the serotonin and
Hold on,
dopamine.
wait. Because I told y'all to use stuff and I have the caveat. We are teaching off of the slides, right? We are tested off of the slides. So when we're talking about even if something is not fully understood, if you see like a mechanism on there, I typically like simplify it for you, right? And I'll say, hey, just know that we have some serotonin and some dopamine activity. That's it. Not the subclasses, not all the other stuff like we talked about before. So make sure that you're weaving in your information because sometimes when we Google and chat GPT stuff, our oversimplification or the real world clinical use and how we do things kind of sometimes creep into what is in the textbook, which are two separate things. Okay? So 5-HT.
So it kind of targets the serotonin and dopamine receptors, but it absolutely does not target the GABA receptor. Like I said, one-trick pony for anxiety. The biggest thing here is not for acute symptoms. It takes about 2 to 4 weeks for the onset to actually happen. It's typically going to be used in second line behind benzos. If you can't give the person benzos for anxiety, you're going to give this drug. They're already typically prescribed benzos, so you're going to taper off the benzos while this is prescribed. There's also going to be less possible abuse for this drug, so it's considered generally safe. The trick that I found for this drug is that it starts with bus, and buses drive slow, so it's got a slow onset, delayed onset. The next drug, zolpidem. Zolpidem is the sleeping drug. Everybody knows it as Ambien. Everybody should know somebody who's been on Ambien before. As a PA, you're all going to be asked to be prescribed Ambien on long overseas flights and things like that. You've seen airplane zombies and things like that. It is a controlled drug, class 4. It works solely on the GABA receptor, has a short onset, about 30 minutes. It's strictly used for insomnia. It has a chemical makeup very similar to benzos, but it works on the benzo receptors, but it is not a benzo. It says it in there. Some notes, it does come in an IR and CR, which is immediate release and controlled release. So IR will get you to sleep, controlled release will keep you asleep. It has some adverse effects. The biggest noted ones is going to be depression and SI. Like she said earlier, the suicidal ideation are going to be the big ones to look out for. And it specifically says bizarre behavioral changes. That can be anything from sleepwalking, sleep eating, sleep fighting, sleep being racist like Roseanne. And if you've seen the movie Role Models, to help you remember Role Models when Sean William Scott is camping and they recreationally took it and like try to keep themselves awake, and then they kind of act funny at the end. That's kind of a bizarre thing. If you've seen it, you know. There's no dopamine hit, so you're not going to have that euphoric effect, and you're not going to have that. You're going to have that craving, like she was talking about earlier, dependence versus craving. There is a physical dependence to the drug because of the GABA receptor hit. You're not going to have the psychological craving that's usually associated with other drugs. So you are going to have the physical dependence to it. Your body's used to it kind of turning off. You take the Ambien, your brain turns off, you go to bed. So you're going to have the physical dependence. So you might have some withdrawal, so to speak, with this drug. The only trick I could really think of with this, if you don't already know what zolpidem is it ends in dim, and you can say zolpidem dims the lights, makes you go to sleep.
So big thing here, remembering your difference between your IR and your CR, and that these are very sought after drugs. A lot of people like to use them. You will also see where sometimes you may prescribe a CR and an IR, because maybe I'm having trouble falling asleep too. So you'll see where sometimes providers will put both of them on board for the patient, because even though they have that CR to help them like stay asleep, they don't have anything to help them fall asleep, right? So you can see both of those formulations on board, and then understanding that when you're comparing these, looking at these advantages, and you'll see this as we continue to go through, because they're comparing a lot of stuff to your benzos, just less effect, right? A cleaner drug is what we're talking about when we're looking at that.
That's all I have. Thank you.
Good job.
Oh, you want to not holler. It's on. I had it on.
Can you hear me now? So for Lunesta, same thing, or similar to the last couple, it's a non-benzo. We remember that it's a class 4 because Lunesta kind of sounds like Luna and GABA, so those both have 4 letters, you can remember that, it's a class 4 by that. MO1A for Lunesta, it does work on the GABA receptors and inhibits enhances GABA inhibitory activity, so it makes you like sleepy and causes sedation. And that's how we connected the Luna to that, because you sleep when the moon is out at night. For clinical uses, it does have a quick onset and a long half-life, so it helps put you to sleep, and then it also maintains your sleep throughout the night. Okay, and then the next slide. Our acronym that we came up with for adverse effects was DREAM, because this one does keep you asleep all night. So the D was for dizziness, R was for risk for suicide, the E was just for the actual drug, the azoplicone, so to help you remember that this goes with the drug. The A is all the A's, so aggression, agitation, abnormal thinking, and then the M was a standout one for metallic taste. And then because it's a class 4 drug, you can remember that people are functionally dependent on it, but there are no physical cravings.
Okay, so the next drug is going to be Xalapon or Sonata. It's a class 4 drug. This is going to be a little more of like a story time kind of deal. So imagine, the title of this, none of this is my original idea. So the title of this, the Sonata Sleep Concert. So imagine you have trouble falling asleep. Your doctor gives you a ticket to a special concert called the Sonata by an artist named Xalapon. So breaking this 2 parts, the performance and the after-show experience. So the performance, the music style, the artist isn't part of the famous benzo band, but they know how to play on the same stage. So they go right to the brain's main calming conductor, the GABA receptor, and tell it to quiet the whole orchestra down. The concert's goal is a very specific type of show. It's designed only to get you into your seat and settle for the night. It's for people who have trouble falling asleep, so it improves sleep latency. Timeline. So this is going to be the shortest concert you ever attend. It starts immediately, so it has a rapid onset. and it's over in a flash, meaning that the entire performance lasts only about an hour. So half-life is only an hour. Okay, now for the after-show experience for the adverse effects. So you might experience some common post-concert feelings. So like any loud event, it might leave you with like a headache or you might feel a little dizzy. You might have an upset stomach, so that includes like your nausea and abdominal pain. And naturally you feel a little sleepy or somnolence. So of course the biggest part of it is that because it's so short, you're least likely to have a concert hangover. So you'll feel refreshed without that groggy feeling or that daytime somnolence. Now as for the dark encore or the adverse effects. So for some people this might not vibe well. So some people might experience some dark thoughts. That includes like your sad feelings, depression, suicidal ideations, and you may exhibit some strange behavior. It can cause people to act like they're in a trance with increased inhibition, aggression, hallucinations, or feel like they're not even in their own body or depersonalization. So really just giving them a really bad trip. Now, as far as habits versus cravings, so people who might use this might feel the need to attend this concert every time in order to fall asleep. So that's your functional dependence. However, you won't find yourself desperately craving the music during the day, so there'll be no physical cravings with this. That is all.
All right, back to me again. So we have this interesting one called orexin receptor antagonist. This is also a class 4 controlled substance. Has a similar function as the rest. It works on the GABA. These ones are very specific. They do not work on the GABA. They work on the oxytocin receptor, which is your wake and your wakefulness and your sleep part of your brain. Not 100% sure how they work, but we have 3 different drugs in this class. We have the S, L, and D. I can't pronounce this if I wanted to. We're talking about the S one. You can be sleeping all day because that's a long ass half-life, 12 to 22 hours. And then we have the Lex, which for the day we go, we're going to be sleeping day and night because again that half-life is like 17, 19 hours, which is pretty ridiculous. And then the last one is the Dario. I can't remember what the thing we came up with that one was, but it's a quick onset and it only lasts about 8 hours, so it'll just keep you asleep at night. So quick bed, quick up with Q, how do you say that name?
So when you're looking at this too, you see how it says orexin receptor, right? You see that these all say rexin. Suvorexin, limborexin, daridorexin, okay? So you see that rex is in all of these, which is telling you your mechanism, okay? So you can try to underline that so you can remember that also.
I'm gonna say up there with that previous slide, it does talk about how it promotes the wakeful transition from sleep by inhibiting those receptors, which is not the GABA, which is the big difference between the orexin receptors and everything we talked about so far. We have the very similar adverse effect as everybody else, daytime sleepiness. The only interesting one was instead of the metallic taste, there's some other funky one-off ones. Our one-off one is the late weakness, cataplexy. Another one also has the sleepwalking, hallucinations, and nothing else really was jumping up there. It does recommend avoiding narcolepsy and severe hepatic dysfunction, which is something that was different from this medication versus the others.
Why do you think that is?
Probably because it's metabolized by the liver, and it's also long ass half-life.
And remember this, inhibiting the wakefulness, promoting the sleepiness, right, that somebody has. So if I have narcolepsy, I'm already like
Passed out all day.
and passing out. So don't make me worse, right? Because now my body isn't going to respond how it should. So now you can make it worse during the daytime for your patients who have narcolepsy.
And then our next couple of medications, they're going to be melatonin derivatives. They work specifically on the melatonin receptors in the brain. The first one's Remelaton. The next medication also has melatonin in there. So if you see melatonin, and you any of these next medications, you can just straight think of melatonin receptor agonists. It acts just like regular old melatonin. Helps you go to sleep. The great thing about this, you get an extra 7.3 minutes of extra sleep while going to sleep 4.6 minutes faster. So that's fantastic. What a great thing. And moving on. Similar adverse effects for this one are kind of interesting. It decreases your prolactin and decreases your testosterone. So not great for dudes at all. It's also an inhibitor of your CYP450 with your fun drugs. Another melatonin, tazomelton. I'm probably not saying that right. Also melatonin receptor agonist. This one is specific. Another interesting medication used for this one is specifically for people who are blind, who aren't able to see and have the wakeful or the day and night wake cycle. So they're able to utilize this medication to help keep them on a 24-hour day wake cycle like everybody else, even though generally blind people are not on a 24-hour wake sleep cycle. They have the same CYP inhibitors, just like the other melatonin receptor agonist, Melatonin. And then we have a check on learning, which is super cool. Which benzodiazepine is most likely to cause withdrawal effects or tolerance?
So I know y'all haven't looked at all these yet. So
Midazolam.
short acting, right?
Although in the streets, it's definitely a lorazepam. People definitely abuse lorazepam the most in the streets.
Oh, alpha, which one? Alpha?
Yeah, that's Xanax.
Yeah.
Breaking them bars.
The streets.
I just worked in the streets for a long time. That's all I'm saying. A lot of bars out there. A lot of bars out there. Not the alcohol kind. I just worked in the ambulance. The ambulance. Everybody was crying about something. As we continue on, we're going to continue to talk about insomnia. Just kind of a roll-up of all the different medications that can be used to help with your treatment of insomnia, from your benzos to your non-benzos to your orexanon to melatonin. And then the stuff on the right is stuff we haven't talked about yet, so I'm not really sure exactly what we're talking about those just yet.
So on this, what I want you to look at, we're going to talk about some of these, we'll get into more detail with this next semester. So just be familiar that these are options that you have for insomnia. There are some other ones that we also use that aren't on here. And then looking at your the medication, so these are things that you would definitely kind of be prescribing, some of the things that we've already talked about. And then looking at what we don't do. Most of the time our patients are put on these and we do not leave them on here for a short period of time. We leave our patients on these meds for a very long time, which is not what we're supposed to do, okay? So just make sure that when you're looking at this, we want them to be something, and we want them to be on them for a short period of time. We do not want to leave them on here. Because the longer that we leave them on here, the more likely we are to experience those side effects, the more likely you are to see that depression that occurs. Yeah.
Ma'am, so for the Seroquel, it says no real benefit. Do we not pay attention to this?
Y'all look at everything. What do you think what would I do with that? How could I ask you?
Of the following, which drug is no benefit
The exam's in the slides, ma'am, the exam's in the slides.
Okay, I would not ask that. Okay, I could give you this drug and give you something that is more preferred, and then you would pick the more preferred option, not the one that says that it doesn't have a great benefit. Okay? Yes. I can't hear you. Which one?
With, like, when you say the no real benefit, like the quantification, that would be for like elderly patients. Like,
It depends. So if I'm having an issue sleeping, you want to help me sleep. What this is meaning by no real benefit is like, if I did a study, I didn't see any increase in helping with insomnia by putting on Seroquel versus not putting it on. But some of your patients will say that it helps them fall asleep. Cool, here you go, if that works. If I'm already using this for something else, itself also is added benefit. So it's saying that like if I were using this, it would be more of an off-label type of situation. Not necessarily that you have to immediately go to like your elderly patient. It's not saying that you have to go to it. It is not a preferred method for a preferred drug.
We just have a couple more slides. The last little bit for us that's new is melatonin, my favorite supplement. You know, if you take that, you can possibly fall asleep, and depending on their formulation, maybe. The worst one for me, Benadryl, puts me down for days, man. Absolutely just the worst hangover symptoms. But you can do Benadryl or any H1 antagonist for insomnia. All these are over the counter, not recommended for extended use. So specifically here, it's just considered off night after 3 consecutive nights to help reduce tolerance. I wouldn't recommend Benadryl ever for sleeping. It's just the worst.
So,
And then,
Jake, are you still on this slide or you want to the next?
I'm good.
Flipping on it.
I'll go to the next one whenever you're ready.
Okay, so on Bennett, when you talk about this, and when you talk to your patients about this, anytime, drug companies are smart, right? And they market to make money. If you look at anything that says nighttime, most of the time it's gonna say there's diphenhydramine in there, which is the Benadryl. They took Tylenol, like NyQuil, they take Tylenol and they'll just be like, cool, if I add diphenhydramine to it, now this is nighttime, so Tylenol PM. So if you look at any of this, make sure that you're letting your patients know, hey, if you're taking this every single day, this will potentially stop working, 1. 2, if they don't get enough sleep at night, they have the worst hangover effect these drugs do. So like, just be aware that there's several different sources and the way that drug companies market it. A lot of your patients may not know that it has Benadryl in it. And they can be taking that Tylenol PM every night because they have pain and it's initially helping them fall asleep. But if they are having issues falling asleep, then they should just take regular Tylenol, not Tylenol PM, because all they did was stick Benadryl in it, charge a little bit more money, and make people drowsy the next day. Okay? So make sure that you're paying attention to and telling your patients, like, if you have an issue with this, then we're using this drug. But whenever they see nighttime or bedtime, most of the time, if you look at the bottle, you turn it around, look at those ingredients, you're going to see diphenhydramine in it, which is your same thing as Benadryl. The other thing, people will try to give this to their kids to make them fall asleep. Sometimes that does not work. Some kids have what's called a paradoxical reaction to this. Okay? So instead of making them sleepy, it makes them hyper. That's my kid. I was like, oh, everybody has allergies. At bedtime, we'll do Benadryl, and during the day, we'll do Zyrtec. Yeah, right. They was like, let's go. It was party time. So you see, some kids, it does work. You can put them to sleep and they're fine. So it just depends. So be very aware of that too, because some of your patients will ask y'all about that. And it's hit or miss on how it's going to react in the kids. But for most adults, it does make them drowsy, and it does stop working over time, and people will continue to like increase their dose on their own because it's over the counter. So then they'll start taking more and more and more energy, and it still continues to not work. Sorry.
And this is our roll-up of all of the different medications, their preferred uses, and special comments.
Wait, did you do this? This one is yours too.
What is it?
This is yours. It's essentially what you did that again. Yeah, and then look at your antidepressants on here. So this is again giving you those benzos, broken them down, short, intermediate, long, right? So that you kind of see. It makes sense if you think about this because you're short. I'm trying to put on. I just want to put you to sleep. I want to knock you out. Versus when I'm looking at my intermediate or my long, those I have more maintenance with them. So I could give a person an intermediate, and if they say, hey, I still woke up, then you can progress to a long, because sometimes you will give a long and people will have a hangover effect from that long, right? They'll still feel drowsy the next day. So make sure that you're understanding the difference between those two and where your drugs fall into that category. And then our antidepressants, we're going to talk about those more in the next lecture, but these are things that we can use before we try to get to those controlled drugs that we talk about, before we try to get to our highly abused or addictive medications that can cause that dependence. where we can sometimes use these meds. Trazodone is a big one that they try to use beforehand, before they progress to like an actual sleep med, and it's also better for our active duty. That was the other thing I wanted to say. A lot of these are control medications. Your active duty service members, make sure that they don't hold these meds for a very long period of time and then try to use them. They're gonna say, oh, but my PA prescribed them. Yes, your PA prescribed them a year ago, and you were just popping these pills. So now I need to understand why. Because your prescription is also expired. Why? Because it was a control. So how good was that good for them if it was a C4? 6 months max. So once they got out of that and you didn't write them a new prescription for it, if CID gets involved because somebody did a drug test, they pop hot for one of these, that's going to be on them. So you need to also make sure that you let them know, because some of these we prescribe as needed or PRN, and they don't use them, and then they run into something and they need them again, and they'll just grab them. So you tell them after 6 months, just throw them away, come back to me, I will write you a new prescription. Don't hold on to these things. Okay?
Okay, is that loud enough? Okay, so we had the anxiety disorders, starting with acute anxiety. So our short acting, kind of for acute management, in the first like 4 to 8 weeks, we're looking at benzos as the drug of choice. And this is, they're kind of, as we've said earlier, we don't want to be on them for too long due to tolerance and dependency on them and physical dependence. But as for patients that have generalized anxiety disorders and they're going to need something long term, they take several weeks to start having benefit. So benzos are really great for like the first month or two as we're titrating a patient onto a long-term anxiety med, but it's not good for the long run. So we remember this as the benzos. Ben is zooming in to calm you down right at the beginning, but you don't want them there for a long time. For the generalized anxiety disorder, so long-term, first line we want to use antidepressants, but like I said in the last slide, it takes a few weeks, and we want to titrate the patient up to a level that's effective for them. But we're mainly looking at our SSRIs and our SNRIs for this, and our TCA antidepressants. Second line was the bucipron and the pregabalin, as we said earlier. And then kind of as a theme with the anxieties, we thought of remembering the gabalins as Gabby is scared to be on the social bus, to remember these two drugs because they kind of pop up throughout the slides. We can also use antipsychotics if there's having refractory anxiety breakthroughs, but not first choice.
So I want you to pay attention to your first and your second line. Anytime you also see refractory, that's also something that I can get all the way down and I'm like, hey, this stuff is not working. So I'm more so focused on your first line agent, and then again, because your bucirone and your pregabalin, they are going to continue to pop up. Just know that those are second line. So you could potentially have something where, hey, my person has gas. What can I do to treat them? If you had a first line and a second line med, which one are you going to pick? Your first or your second line? First. My first line is first. Okay? Your second line becomes second. So if you see two things, just like when you are out practicing and you have all of these drugs at your disposal and pick them out, if you see something that is first line, always pick your first line med. We have more research with that. We have a better result with that versus using our second line. We use our second line because our first line didn't do what we thought they were going to do. Then when we talk about refractory, that's because nothing else works and you're like, oh crap, I need something. Hail Mary, you're refractory. Okay? And then we talked about our atypicals already and how we have side effects and all the things that come along with that. So it's like kind of put that in your mind as to, all right, first line, that's where I'm going first. I'm guaranteed that I'm going to get what I want out of this almost. Second line is like, okay, that didn't work. And then your refractory is like, nothing else works. Hail Mary, what can I do?
So for panic disorders, same first line, we're looking at SSRIs and SNRIs for long-term management of someone that frequently has panic attacks or refractory panic attacks. But for acute episodes where it doesn't happen often, we can still prescribe benzos just to manage that specific, like the one-off instances where they're having panic attacks. Specifically, we can look at clonazepam. Fort is preferred because it's a little bit longer acting, so there'll be less of the short-acting side effects. But if they're having a lot of panic attacks and we're just trying to bring them down, kind of lower their level of anxiety to prevent the panic attack from happening in the first place, looking at the SSRIs and the SNRIs.
And then you see this, is kind of what we were talking about before, where I have approval, FDA approval for it, but it doesn't mean that I can't use any of my other benzos. So any benzo is effective, just labeling wise, if you were to go and look it up, it would only say that it's on label for the clonazepam and the alprazolam, and any of your other ones, it will probably say off label in parentheses, like you can use it, but it's not FDA approved for that, we know what it was.
And then social anxiety disorder, so Gabby's gonna come back on this one, I'll explain the story in a second. But first line agents is still SSRI and SNRI, but some other treatment options, we can use our benzo again, the clonazepam, right? And then gabapentin and pregabalin are a second line agent. We can also use beta blockers to kind of help prevent, but this is more for like performance anxiety, so kind of, again, more of an acute treatment for it. And then buserelin is only effective if it's used with other antidepressants, so we wouldn't want to use that by itself for social anxiety. And then when we were kind of chatting, trying to come up with something, we said Gabby is a type B person who's scared to be on the social bus, to kind of remember the different other second line drugs, but our first choice is still going to be the SSRI and the SNRI. And then PTSD, so first line again is SSRI or SNRI for long-term management of patients that have PTSD, but we can also look at antipsychotics, and we can also look at prazosin, which is an alpha-1 blocker, and clonidine, or other anticonvulsants for like the impulsive behavior and the hypoarousal that comes back when they're having an episode. And then the way that we kind of came up to remember this was say a prayer for prazosin before working with type A people because they're a nightmare to be around. So think prazosin for nightmares. And then they're hyper and they need to calm down with some quantity.
Okay, so we'll stop right here, but when we're thinking about these medications, what you'll see in practice is a lot of this stuff starts to become off label. You'll see propranolol a lot when we're talking about like performance anxiety. When you're talking about being in school, I remember I was in pharmacy school and they were trying to put this, so like if anybody has testing anxiety, things like that, you'll see we'll do propranolol in those types of situations. Looking at your PTSD, there's lots of studies that are starting to go into this and how to treat it. It's very prevalent in our population, of course, so we're talking about those nightmares, and we talk about like some of the impulsive types of behavior that our patients may have, or our impulsive behaviors, to see where that results in response. So for this, what I would say to do is write down what the condition is, and then write what drugs you can use to treat that condition, okay? And then go back to the very